Hi, everybody. Sorry about that. We are having some technical difficulties, but GoToWebinar kicked all of us off, so we apologize. So we're going to get rolling again here. Welcome again to our June webinar. We're happy to have you. So just a couple housekeeping items. Again, you are muted, but you can put questions in the chat and we'll answer them at the end of the presentation. So Bamboo Health is one of the largest and most diverse care collaboration networks in the country. Our network enables providers to improve whole person care with a full view of their patient, including physical and behavioral health, all within the clinical workflow. The goal is to improve health outcomes and provide more efficient and effective use of resources. Our vision is to revolutionize care collaboration for the improvement of whole person care. So we're really happy to have you here with us. Today, the focus of our webinar is on prescription drug monitoring programs, or PDMPs, and one of our related solutions to support them. We'll be taking a look at dispensation trends of controlled substances pre and post implementation of Bamboo Health's PMP Gateway in the state of Indiana. We have two guests with us here today. First is Kara Slusser, who is Director of Indiana's Prescription Drug Monitoring Program, INSPECT. She guides government and business executives in the health and human services space. She is responsible for implementing PMP practices that assist providers to effectively flag at-risk patients and curb prescription drug misuse. With a focus on strategic state-based initiatives, Kara worked with Bamboo Health and state partners to launch the INSPECT State Integration Program that enables integration of controlled substance prescription histories into electronic health records, providing real-time physician access to PDMP data with care team workflows. Kara is a member of the PMP Interconnect Steering Committee, Regional Judicial Opioid Initiative, and the National Association of State Controlled Substance Authorities and the National Alliance for Model State Drug Laws PMP Resource Group. So thank you to Kara for being here. And second is Joe Carhart. He's part of our Bamboo Health data science team, where he conducts scorched the earth literature reviews and hosts brainstorming sessions with internal and external collaborators to design, deploy, and complete studies whose focus is trained on testing the effectiveness of and improving upon the suite of our product offerings, as well as discovering new product offering ideas. He, along with his teammates, communicates these findings via webinars, lunch and learns, blogs, and peer-reviewed publications. Joe holds a Ph.D. in epidemiology, a master's in psychology, and a bachelor's in computer science. So thank you both, Joe and Kara, for being with us today. I'm going to kick things over to Kara, who's going to talk a little bit about Indiana's PDMP and the state's work with us to implement Gateway. Thank you, Kara.
Thank you. Hi, good afternoon, everyone. Can everyone hear me? Yes.
I can.
Okay. All right, good. Well, thank you so much for the opportunity to talk to all of you today, and thank you for joining this webinar. I think that we have a great story here in Indiana, and we're excited to talk about our progress over the last several years and our partnership with Bamboo. To give you a little idea of where we started, Indiana's PDMP began in, it was 1997. Originally, it was used as a law enforcement tool and became primarily a healthcare tool in around 2006. So I came on board in early 2017, and so by that point, you would think that it's, the program had been around for long enough that most providers would be using it. I was absolutely wrong about that. I was telling someone a couple of weeks ago that I think about 40% of our practitioners at that point in time had ever used it. I ran a recent audit from 2016 and realized that only about 28.6% of our providers were actually using the PDMP at that time, or had ever used the PDMP at that time. So we really had a lot of work to do to identify barriers to widespread use of the PDMP program. We had to really understand what it was that we could, what we had to improve on to make this an efficient and effective tool for practitioners to identify substance use disorder and potentially harmful combination drugs that people were getting from different providers. So we were really tasked with figuring this out and making this a program that was really useful for providers, and was easily accessible to providers. At that time, we had, in 2016, which was just before I started, we had fewer than 3 million patient inspect reports per year. So in 2016, we had approximately 2,296,000, which isn't terrible, but nothing compared to the scale that we have today. We introduced in late 2017, we first in 2017 moved to the AWARE platform, which is what we are currently using, and we introduced a statewide gateway initiative. This was something that would provide one-click access to patient PDMP reports for all practitioners across the state, regardless of where they worked, a hospital, a clinic, a pharmacy. It was incredibly easy for them to simply click a button and review that patient prescription history before deciding whether or not they wanted to prescribe a controlled substance to that individual. We got a lot of pushback, and I have to say I'm really proud of the fact that we fought so hard to get this implemented in Indiana. It became something where I think most people didn't really understand it at first, and a lot of people did not believe that it would really work. So we had a lot of pushback from our legislature at that point in time. We had to go in and speak in front of the Public Health Committee on more than one occasion to really fight for this program and explain why we really felt it was necessary to make this program something that was used on a daily basis by practitioners to help them understand their patients' prescription histories and help provide better care to their patients and keep them, keep their patients from developing substance use disorder. It was something that we fought, my entire agency fought very hard for, and we finally got approval in late 2017. And so 2018 was the very first year that we had implemented this program statewide. Here we are in 2022, and currently we have just over 93% of our practitioners actively using Inspect to check their patient prescription histories before prescribing controlled substances. So we went from 28% to more than 93% during that period of time. So I'd like to turn it over to Joe to talk a little bit about how the implementation of statewide gateway has actually impacted not only prescribing habits, but the use of Inspect by practitioners across Indiana.
Awesome, thanks, Kara. So that's a truly inspiring story of both grit as well as perseverance. So kudos. We have a wide range of approaches and suite of tools in our toolkit to help Kara accomplish her goal of showing that Gateway adds value to her campaign, from running basic statistics that capture and summarize the general landscape of certain elements of our data, to applying traditional epidemiological methods to our study designs, to meta-analyses, all the way to applying state-of-the-art machine learning models to our structured as well as unstructured data. The current analysis showcases one of these approaches, which at its core is a pre versus post intervention type of study, where the intervention you can visualize in this instance is Gateway rollout. If you wanted to put a wee bit finer point on this, then you can consider it an interrupted time series, or ITS study design for you epidemiologists out there, where we use segmented regression to obtain basic statistics such as means and slopes. So the research question then, as it is now, is do the PDMP products such as Gateway add any sort of value to our end users? And the short answer is yes. And based on the success that we've observed before, like in different states as well as meta-analyses, we wanted to take a look at what was going on in Indiana, as Kara has already mentioned. Speaking of the different states that we run these for, we've currently run them for 12 different states, and they each tell a really cool and unique story. And today we'd like to focus on Indiana's story. So next slide, please. Just a real quick note on metropolitan status. The literature indicates that the general public or non-institute, epidemiologists love to use fancy terms, right? So we like to say non-institutionalized community dwellers. It just means you and your neighbor and anybody that's not in jail. So the literature indicates that folks that reside in rural areas are up to 5-fold more likely to experience adverse outcomes related to opioid prescription use compared to their age and gender matched counterparts living in urban areas. And this data is derived from studies, like 17 different studies spanning from 2007 to 2019. And they all pretty much say the same thing. Next slide, please. So the definition of rural and urban status is based upon 4 canonical government agencies definitions. One is the U.S. Census Bureau definition. The second is from the Office of Management and Budget. Third is the Economic Research Service from the U.S. Department of Agriculture. And the fourth is the CDC's definition. Centers for the Medicaid and Medicare, CMS, uses the first one by the U.S. Census Bureau, as do we currently. But that doesn't really tell us like anything about it. So real quickly, let me define urbanized area and urbanized cluster, because this does factor in to subsequent analyses that we're going to be running through. So a UA, an urbanized area. This is any combination of a census tract / block that contains 50K or more residents, while urban clusters, this is a census tract / block containing at least 2,500 residents up to 49,999. So because the Census Bureau doesn't actually define rural per se, any tract or block outside of these 2 urban categories is considered rural. Side note, there's about actually 15 of these different definitions that are used in the research, but all tend to start with one of these 4 definitions, and they just bolt different things on. So there's no perfect definition. Some very interesting definitions, though, that I'm looking really forward to incorporating into our analyses are the IRR, which is the Index of Relative Rurality, scales from 0 to 100, 100 being super duper rural, 0 being urban, and takes into account, instead of urbanized, the idea of urbanized population density, basically urbanized area and urbanized cluster are all deal with like population density. What the IRR does is takes into account not only population density, but population size, remoteness, as well as built up area. And another real cool rurality metric, colloquially referred to as the tractor factor or the tractor index, is in press right now by Dr. Ostrach and company out of Boston University School of Medicine, looking really forward to reading that paper and trying to incorporate that definition of rurality into our analyses. Next slide, please. Okay, so before diving into anything urban and rural, first let's get a grasp on what's going on globally. So for the next couple of slides, I'd like for you guys to imagine a pie. So the analogy here is a pie. This, what we're looking at here, is the whole pie. Each schedule represents a different slice of the pie, 2, 3, 4, and 5. 5 slices in one pie. Across time, overall, the whole pie, all the opioid dispensations in Indiana decreased on average by about 18%, and did so at 120% faster rate after Gateway implementation. And so what we're comparing here, just in terms of really basic statistics, are the means pre versus post and the slopes pre versus post. Next slide, please. When we stratify this main trend by patient, urban, and rural status, we observe patterns similar to what the literature reports. That is, patients from rural areas appear to bear a disproportionate amount of opioid dispensations, and some hypotheses from the literature are that patients from rural areas don't have the same access to healthcare as their urban counterparts, or that the prevalence of chronic pain is higher in rural areas for myriad reasons. And we'll circle back to this in just a second because we've got some interesting data to show you. Next slide, please. But before we do, I just wanted to flash the numbers and equations that were used in the calculations of these descriptive statistics for you guys so that the viewer can double check my math as well as replicate any of these findings. All right, next slide, please. Sticking with the pie analogy, we can imagine that C2 or Schedule II dispensations are a slice of that larger pie. So as with the main trend for all opioids, we observed a 23% decrease in C2 dispensations after gateway implementations, and these dispensations decreased 130% faster after rollout. But what we really want to know is how big of a slice this is relative to the other slices, and how big of a bite, in other words, the providers in Indiana took out of the whole pie. So fortunately, we can do the math for this, and the answer is 68%. All right, sorry about the technical difficulties there. I'm just going to say that just only helped to build the suspense for the cool stuff that's coming. All right, so back to kind of where we were. Fortunately, we can do the math to figure out how big of a bite these C2 dispensations took out of the whole pie. And it turns out in Indiana that this was 68% of the overall decrease in opioids, the whole pie, that was accounted for by Schedule II dispensation decreases, which is a good thing. Next slide, please. When we stratified this main trend by patient, urban, and rural status, we observed something pretty interesting. Despite Schedule II dispensations being 18% higher overall, like referring to the mean here, for patients from rural areas, the rate of decline, or the steepness of the slope, compared to urban patients, was 67% steeper. It's relatively hard to see because we're dealing with comparing changes in slope with really small numbers, but what this means is that should this trend continue, is that providers in Indiana are moving patients from rural areas off these dangerous opioids, Schedule II opioids, faster than the patients are moving off of C2 dispensations in urban areas. So this is good because it challenges the literature a little bit. It's a favorable outcome among rural inhabitants. Next slide, please. And here, this is kind of the pattern for all of these. I've included the numbers as well as the formulas to allow the viewer, after the slide or after the webinar is over, should they be interested in the slide deck, to be able to run these numbers themselves and replicate the work. Okay, next slide, please. Okay, switching gears now to sedatives. Overall, sedative dispensations decreased on average by 6% after gateway rollout, but what's interesting is the delta in the global trajectory. Prior to rollout, the trend was for increasing sedative dispensations, and afterwards, the trend was for fewer and decreasing dispensations. So this equated to a 241% rate change in sedative prescribing patterns. Next slide, please. When we stratify the main trend by patient metropolitan status, a story very similar to C2 emerges for sedatives. That is, despite the mean being slightly higher among rural patients, we observed a sharper rate of decline in these dispensations compared to urban patients. Next slide. And similar trend, if you want to do the math, you're more than welcome. Next slide. So we've been observing an overall increase in stimulant dispensations nationwide. This trend does not just hold true for Indiana. It's true nationwide. What's interesting and cool in Indiana, though, is that this increase in stimulant dispensations slowed by 52% after Gateway rollout. So although there's still an overall increase, the growth of the increase is kiboshed just a little bit after Gateway rollout in Indiana. Next slide. So moreover, the mean was lower among patients from rural areas, which is an interesting finding, I think. We didn't observe any differences in slopes between these two subgroups after Gateway implementation, but we did observe a sharper decrease in stimulant prescribing among urban patients. And this is good news because it appears that stimulant prescribing in urban areas might play a role in that global trend. It might play a pivotal role in the overall increase in stimulant use nationwide. Next slide. And we can go ahead and go one more. I don't think folks are gonna whip out their calculators right now, but they're more than welcome to after the slideshow, or if we wanna go back and revisit any of these calculations, I'm more than happy to do that. All right, so now let's end with what I think is a really interesting finding. Here we see that overall buprenorphine MAT dispensations increased on average by 113% after Gateway rollout, and they did so at 136% faster rate after implementation. Next slide. But a really cool story emerges when stratifying patients by metropolitan status. Not only was the mean higher for patients in rural areas, 57% higher, the rate of increase for these meds, these medication-assisted therapies, was sharper compared to patients from urban areas, 86% sharper, or 86% steeper slope, rural versus urban. This finding challenges the literature with respect to rural patients not being able to access treatment for opioid use disorder as easily as their urban counterparts. Moreover, the literature reports a higher prevalence of opioid use in rural areas, so this finding in Indiana also might mean that patients living in these areas are getting the treatment that they need so that they can thrive. And here is the numbers as well as the equations. All right, so in conclusion, these are just like big picture conclusions. The analysis has shown that, and again, this is, it's one step of many, but just the analysis so far is awesome. It shows improvements in several key outcomes following Gateway implementation. Future work will consider patients vulnerable to misuse, chronic pain patients being able to identify who's a patient on medications for chronic pain, which is very, very tricky. But nevertheless, we love a good challenge, and we're pursuing this to try to figure out if we can identify patients with chronic pain, as well as quality of opioid prescribing and other variables. So in sum, we observed an 18% decrease in daily opioid dispensations, a 241% faster decrease in sedative dispensations, a 52% slowed increase in stimulant dispensations, and 113% average increase in MAT dispensations. And based on user feedback that we've received with respect to the urban and rural stratifications from other states, as well as internal colleagues, we got a lot of really cool stuff cooking in the pipeline for that as well. Thank you, guys.
Thanks, Joe and Carol. It's not Carol, I'm sorry, Kara. Thank you both. We do have a few questions that have come in, so I will help field those. One question is it possible to get pre and post data specific to a hospital system or medical group? Not sure, Joe or Kara, who's better to ask.
That's actually something that we have been asked quite a bit. Technically, yes. Technically, the answer is yes, but there are a lot of issues with that, mainly because it's hard to compare one facility to another. You might have a hospital that deals with a lot of cancer patients, and you might have a surgical unit. You also might have facilities that share doctors. So one doctor may work in two different hospitals. We have that a lot here in Indiana with IU Health being next to Eskenazi Health, which are two massive, massive hospitals, and they share a ton of doctors. So you wouldn't necessarily be able to see exactly how much they're prescribed. I mean, so if you're looking at the overall prescribing habits of individuals in a specific hospital, you're not accounting for the fact that they're really moving around and prescribing some in one facility and in another. And then, of course, you're not accounting for the medical specialties of these providers that may be in one particular hospital because of their specialized services there. Hopefully that's kind of making sense to everybody, but we do get asked a lot about comparing one hospital to another, or even comparing all providers and looking at, we just received a request the other day for information about the top 10 prescribers in our state. Well, first of all, we're not authorized to give that out, but second of all, even if we could, I mean, undoubtedly you're going to be pulling people within specific medical specialties like oncologists and pain management specialists who are going to be prescribing more opiates than someone who's a family physician, for example, or a pediatrician. So it's really hard to compare apples to apples like that.
Thank you. Is it possible to conduct a similar time series analysis for fatal and non-fatal overdose?
If only we had the data.
Yeah, Indiana's laws changed a couple of years ago, which was a really great thing for us. It established very specific guidelines for non-fatal and fatal overdose data collection and reporting to the state. And so once those laws changed, yes, I mean, we actually, if you look at overdose data from around the country and you're simply looking at just the numbers, it looks as though Indiana has had this massive increase in overdoses in the last 2 years. But what they don't really account for is the fact that because there was a change in the law that required EMS or first responders to report all fatal and non-fatal overdoses to the EMS reporting system within 48 hours, and it also required all coroners to report suspected overdoses along with toxicology screens and an inspect report. That all has to be documented and sent to the Indiana Department of Health. So because we have more accurate data collection and more timely reporting of that data, we're finally able to collect a lot more data on that, or get a more accurate idea of what our overdose situation is in Indiana. But we really can't look at, you really can't rely on data prior to, I think 2019 when that law changed.
Thank you. Sorry, we have several questions coming in. I know technically we're past time, but we also had some technical issues. So maybe we'll get to maybe one or two more of these. The buprenorphine statistic, solely MAT dispensations, or does it account for regular pharmacy dispensations from any doctor? Hopefully I'm understanding that question correctly. And perhaps, Joe, you could elaborate. Did you look at beyond just buprenorphine for MAT as well?
No, to answer that part of the question, it was buprenorphine specifically prescribed for the treatment of opioid use disorder. because it can be, and is we do see this in the data as well, it's prescribed for pain management. And so those are two different things. And we did not include patients who had been prescribed buprenorphine for pain management. MAT here does not, the definition for MAT here doesn't include methadone either, or I'm not sure if it's even reportable in Indiana, but naltrexone. Naltrexone is also considered an MAT.
Suboxone.
Yeah. Suboxone is included. Suboxone is included.
Oh, it is. Okay. I wasn't sure. Okay. All right. Yeah, so all of that, all of the medication like that, the methadone and buprenorphine, stuff like that, if it's dispensed at a pharmacy, then it gets reported to inspect. But currently, if it is dispensed to a patient at an opioid treatment program, it's not collected. And we are in the process of changing that because the SAMHSA regulations changed in 2020, allowing us to collect that data for the very first time. And we have since been working with Bamboo to figure out how to collect that data and display it in a manner that is consistent with the regulations outlined by SAMHSA. And it's something that we continue to work on, and I'm hopeful that by the end of the year, we will have a way to ingest that OTP data and create some type of flag or indicator in a patient profile to let their physicians know when they are seeking treatment for substance use disorder.
Great, thank you. So one more, and then we'll wrap things up. This one's maybe a little bit more hypothetical, but what do you think is driving this rural and urban divide? And can the difference be a function of the number of prescribers and dispensers available to patients in those geographies?
Oh man, that is a can of worms. Gosh, so there's so many factors that have been elucidated in the literature, from just lack of access to care, diverting among family members in rural areas, to even, there's this one report that I read recently. It was a survey that polled patients from rural, or no, polled physicians of patients from rural areas. And they reported that a lot of their patients that they find seek drugs or seek opioids not for personal use. They use it as a source of income in rural areas. So there's so many things, like not just the presence of a higher prevalence of chronic pain in rural areas due to factors such as, more manual labor, perhaps, and that's reported in the literature as an association. More manual labor in these areas equals later in life higher prevalences of chronic pain, which means more opioids to treat the chronic pain, so that the folks who have the pain can continue going to work and maintain their livelihood. But that's just the patient side of things. It very well could be prescriber factors as well. There's so many things. I know I'm being vague. I'm so sorry that I'm being vague, but yeah, it's a huge can of worms, and there are both. I guess if I were to answer this more succinctly, there are both manifest, as use some psychological terms here, manifest as well as latent patient factors, as well as manifest and latent prescriber factors. And teasing all of those apart from a data science / statistics point of view is, it's like imagining a gigantic bowl of spaghetti that you want to unwind. It's not impossible, I don't think, but it requires deep thought and sophisticated models in order to tease those factors apart. Great question, and that's something that we're trying to at least take small bites out of as we move forward with this urban and rural stratification of the data.
Great. Well, thank you. I know we are beyond time. And again, thank you so much to everyone for your patience with our technical issues. I see there are some questions we didn't get to, so we'll try to respond to all those via email. And you can also email solutions@bamboohealth.com. And again, thank you so much, Joe and Kara, for your time today and insights. We really appreciate it.
Thank you all so much. Appreciate it.
No problem.